Alright, before we move on to restrictive disorders, I want to just briefly stop and take a moment to review what you should have heard in the previous few slides. What we were discussing, the main theme for the last few slides, were what do we need to overcome in order to get air flow in and out of our lungs. Number one, we have to overcome any obstruction. That means obstruction in the air passageways, whether it be in the lumen itself, from the wall of the air passageway, or destruction of the air passageways, because as we've seen, destruction of alveoli means that we compromise gas exchange. So that's number one. Number two, we need to overcome the elasticity, the elastic recoil of the lungs. Those are the two big problems. Now, when we're speaking of overcoming obstructions of the air passageways, primarily we're talking about radius, right? According to Poissonier's law, radius to the fourth power is the number one issue with resistance, and that's what we're talking about when we're discussing obstruction, of course. So we have to overcome the resistance of the air passageways. I just finished telling you about the chronic obstructive pulmonary disorders that consist of emphysema, chronic bronchitis, and asthma. Asthma, of course, is an issue with IgEs responding to allergens, binding to mast cells and basophils, and profound release of histamine. We know that histamine will alter Kf, the permeability coefficient of a capillary bed, and also cause vasodilation, which means we're going to have increased blood flow to the pulmonary capillary beds, and we're going to have increased permeability. So fluid will leak from the plasma into the alveoli. That fluid plus mucus and bronchospasm are going to exacerbate the problems with obstruction and lead to also problems with gas exchange. When we talk about the mucus and the fluid that's there, it's going to increase the distance for gas exchange. With chronic bronchitis, we recognize that this is profound production of mucus and also hypertrophy of the air passageway walls. And the hypertrophy goes into the lumen. So with chronic bronchitis, this needs to last for at least 3 months and have recurring bouts of it throughout a year, and then be consecutive with those recurring bouts for about 2 years. Then that led us to emphysema, and I was telling you how it's the destruction of the alveolar walls with the destruction of elastin by the synthesis and release of elastase by the macrophages, and there seems to be an imbalance in these individuals, a predisposition, if you will, for the overabundance of elastase and not being tempered with the amount of antitrypsin. Now, if you would like to see a flowchart with the elastase and antitrypsin and how that's supposed to be balanced, you could see that in your book on page 717. So now I would like to focus on overcoming the elasticity of the lungs, the issue of restrictive diseases. Excuse me. Now, one thing I want you to keep in mind as I introduce the restrictive diseases is that we can actually determine whether or not a person has an obstructive problem, a problem with resistance in their air passageways, a problem with that first issue with how do we get airflow in and out of our lungs, overcoming resistance. And we can also determine if the person has an issue with overcoming the elasticity of their lungs, restrictive disorders. We can do that through spirometry. It's very, very easy. So when I'm done with this restrictive disease, I'm going to go over some of the lung volumes and capacities, and then basically tell you the tests that we can use to discern if a person has a restrictive disorder, too much elastic recoil of their lungs, or obstructive disorder, which means too much resistance in the air passageways. And I'm really hoping that you were able to do some spirometry in your physiology class. If you were not able to do that and you want to learn more about these breathing disorders, I invite you to come to my official lecture that I will give to students on spirometry and how they tie into these different breathing disorders. And you can also come to my lab and you can actually do these spirometry labs with them. They're really fun, they're really short, and you get a lot out of them, I think. So if you're interested in that, give me an email, let me know, and I will let you know several times when you can do that. There are labs in the morning on Tuesday and Thursday. There's also labs at night on Tuesday and Thursday. If you choose for the night labs, they meet from 7 p.m. to 10 p.m. And the morning labs meet from 9 a.m. to 12 noon. And the night lab is run by my partner in crime, Marcelo Pires, who is wonderful. So although you may not have me if you choose the night lab, you will still be in excellent hands, I assure you. Alright, so now let's move on to the elastic recoil being the problem. This is an issue of restrictive disease. It's defined as having a difficult time inflating the lungs. Again, the lung recoil should be in balance with the chest wall recoil. Both of those want to pull in different directions. In persons with restrictive disorders, the lungs are winning, just to say it very simply. Their recoil is too great. So they have a problem with inhalation. So obstructive disorders, primarily a problem with exhalation and exchange. Restrictive disorders, a problem with inhalation. Now you're going to see that they have very distinct spirometry issues. They're going to have a reduced total vital capacity, and I will explain to you what that is. They're going to have normal airway resistance. They're going to have reduced functional residual capacity, and they're going to have reduced FEV1. But you're going to see that their ratio, I'm going to explain this, of FEV1 to FRC is still a normal ratio because both of them decrease proportionally. And that's going to be very different from what we see in individuals with obstructive disorders. And again, that's why we can use spirometry as a diagnostic tool. So what are some examples of restrictive disorders? Pulmonary fibrosis, where the collagen is replacing the elastin fibers. Collagen does not stretch. It does not budge. And so these persons have these people have a very difficult time inflating their lungs. My neighbor, about 3 years ago, died from hereditary pulmonary fibrosis. And I can think of several other ways I'd rather die. If I had to pick a cancer, I think I would, even the most horrific one, than die of pulmonary fibrosis. Daily tasks like washing her hair proved a challenge because that was too much exertion. She could not get air in her lungs just to wash her hair. It was really sad. A pneumothorax, which means air has been introduced into the pleural cavity, and this means now that the pleural cavity has the same pressure as atmospheric pressure, and that causes the lungs to recoil. And I'm going to tell you about tension pneumothorax, trauma pneumothorax, spontaneous pneumothorax, hemothorax, where it's blood inside the pleural cavity. How does that get there? It's good stuff. Broken ribs can easily lead to a trauma pneumothorax, particularly the broken rib protrudes through the chest wall and breaks through the parietal pleura. And we can also have problems with inflation, of course, with muscular diseases like myasthenia gravis, where there might be flaccid muscle paralysis due to destruction of the nicotinic acetylcholine receptor. There might be skeletal or chest wall deformities like kyphosis, which is an exaggerated forward curvature of the spine, the humpback, or scoliosis, which is an exaggerated lateral curvature of the spine. Ironically, you see emphysema here. Well, emphysema can be a double whammy. It can be both obstructive and restrictive. It is primarily considered to be an obstructive disorder. Hear me on that. But there is an element of restrictive disorderedness to it, and it's because of the destruction of the surfactant or type 2 cells. Surfactant lack from smoking leading to adult respiratory distress syndrome, surfactant lack in infants, premature infants. For an infant, respiratory distress syndrome means that there's too much surface tension. And again, my example yesterday or last night when I was trying to finish my lecture during an asthma attack was that if you put water in between your thumb and your finger and you pull it slightly apart, your two digits apart, you'll see that surface tension holding the water together. And that water, you can make it look like an hourglass in between your fingers. And that represents surface tension, the water molecules holding together between a liquid and a gas phase. And you can pull your fingers easily apart and disrupt that. You're stronger than that surface tension. But if you think about that happening, that same volume of water and 1 million alveoli in each lung, and then you think about a young infant trying to overcome all of those millions of areas of surface tension, it should come as no shock why those young babies die from exhaustion. Literally exhaustion. Profound consumption of ATP to get skeletal muscle contraction of the diaphragm, the external intercostals, the scalenes, the sternocleidomastoid muscles, the erector spinae. To watch them breathe is horrific. They arch their back. They're trying to open up the thoracic cage to cause volume changes. That has to be number one. Remember, we're not vacuums. We don't suck in our air. We have volume changes first. Then that creates pressure changes in our lungs. And then the air can flow. And the reason why it causes pressure changes in the lungs is because as the chest wall expands, the lungs need to be compliant. Well, if there isn't any surfactant, then deep in the lungs, they aren't able to stretch open. They aren't able to open all of those small alveoli, which have the greatest tendency to collapse, according to Laplace's law. It's truly a horrific thing to witness. Thank goodness for the synthetic forms of surfactant that we now have. It's truly a miracle. The exosurf is, of course, what I'm referring to. But I found last night and posted on Blackboard an NPR, and as in Minnesota, a radio program where they were talking about a study going on in Minnesota to test a new artificial surfactant. It's about a 5-7 minute radio program, and I just thought it was fun to listen to. Finally, cystic fibrosis. We've learned this before. It's a problem with the chloride transporter. That means that you're not going to have as much chloride going out, not as much sodium and water going out. The mucin, that's the precursor to mucus, then will not be appropriately watered down. And this is going to cause a problem with thick mucus secretions, not watery and scant, but thick. And it's going to desiccate, and that's going to disrupt the surfactant. So in the end of the day, the children with cystic fibrosis are going to present as if they have surfactant lack. They don't, of course. Please hear me on this. They have normal type 2 cells. They are making surfactant, but it's not working appropriately because the mucus is there and keeping those alveoli clogged up and closed. So let's start our story on pneumothorax. Let's first start with spontaneous pneumothorax. And I'd like to just be a little bit anecdotal here and just kind of talk through this a little bit without being too structured with material from the book or other physiology books. Okay, so let's talk about pneumothorax. These are really interesting. Pneumothorax means air in the intrapleural space. Now let's go back to the pleural cavity itself, and let's remind ourselves the purpose of this space. Why do we need the intrapleural space? We need the pressure there to be negative pressure. It reflects a fight between the chest wall trying to recoil outward and the lungs trying to recoil inward. The pleural fluid there then is being pulled apart, much like that fluid, the water in between your fingers. Let your index finger represent your chest wall and your thumb represent your lungs. And that water in between, that little drop of water, let it represent pleural fluid. And the space between your finger and your thumb, let it represent the pleural cavity or intrapleural space. And as you pull your finger and thumb away, you can see the surface tension developing. In that time, in the pleural cavity, we want surface tension. This is different than what we're trying to overcome in the alveolar spaces. We want that surface tension because that's going to create a vacuum and negative pressure. So that's going to mean that the chest wall and the surface of the lung are adherent to each other. When you breathe in, the lung needs to be compliant and the chest wall gets to recoil. When you exhale, the lung gets to recoil, and now the chest wall has to follow the lung. So, any fluid that accumulates in the pleural cavity is immediately drawn out of the pleural space into capillaries, and this is going to create a vacuum, a minus pressure. When you have an effusion, as we learned, it's going into the pleural cavity, and that can disrupt this balance between the chest wall and the lungs, of course. But in the normal condition, like I said, this negative pressure is to keep the lungs following the chest wall and vice versa. As I said, there are no bones in the lungs to keep them open, and they are not muscular structures. They cannot change their volumes on their own. So we need some sort of way to keep them tightly adherent in some way to the chest wall. So that pleural cavity, I like to think of it like a suction cup. Have you ever tried to put a suction cup on a wall and it bounces right off? You pick it up, you push it on the wall again, and it bounces right off. What do you do to that suction cup? That's right, you lick it. And what you're doing then is basically creating a fight between the wall and the suction cup. The suction cup wants to recoil away from the wall, but by licking it, you create water in that little cup, and when you push it on the wall, you're having surface tension from the water molecules overcome the tendency of the plastic of the suction cup to recoil. Now it's firmly affixed to the wall. Okay, so in pneumothorax, though, there's a spontaneous type. Let's start with that. Spontaneous type of pneumothorax, this is where a section of the lung tissue itself becomes filled with what's called an air-filled bleb. And that sounds like I'm making it up, but it's really not. And we're not really sure what causes these blebs. They just happen. And it's sort of like a little swollen part of the lung, and it bursts through the visceral pleural membrane and into the pleural cavity. And because you've got positive pressure in the alveoli, the air will just flow from the alveolus across the lung wall and into the pleural space, the pleural cavity. And then that means the pleural cavity in that region goes from a minus to a positive. And as soon as you get this positive pressure, the lung begins to collapse, and you've got a collapsed lung. That section that collapses is called an atelectasis. So pneumothorax refers to the actual air in the chest. Atelectasis refers to the outcome, the collapsed alveoli. So again, no one really knows what creates these blebs, and it's not really known why they burst. Some people who are very tall, like ectomorphs, like I said before, the surface, the very top of their lungs, if they're very tall individuals, there's going to be even more minus pressure at the very surface of those lungs, at the apical section. And so there might be more tendencies for these blebs to kind of bulge outward into the pleural cavity. And if there's more positive pressure internally in the lungs, then it's like a blown out tire. You know what I mean? When you start to see it bulge a little bit and you know the tire wall is getting weak, and then all of a sudden it can rupture, that's what a bleb looks like. So the condition, as I said, is most often seen in tall boys and young men. Why boys and young men? Well, they tend to get taller than women, of course. So it's said that the pressure of the pleural cavity is lowest on top, like I said, due to gravity pulling most of the fluid downward, and therefore the top of the lung is most susceptible to these blebs bulging out because of no counter pressure. Well, how about traumatic and tension pneumothorax? Traumatic pneumothorax is caused by trauma, but one of the characteristics of pneumothorax is that the inhalations and exhalations are involved in the trauma type. Let me explain. Okay, so first of all, do you know what's really good at causing trauma pneumothorax? Arrows. Because if you think of Native Americans shooting arrows, they shot them from pretty good distances away. And by the time the arrow got to the victim, they didn't have the penetrating power that you usually see on television. It usually would hit the rib cage and bounce right off. A lot of them did that, just depending on how far away they were. Well, that would cause this kind of trauma pneumothorax because it would hit between the ribs, between the intercostals, and pass through and create just a little opening here in the pleural cavity. It just broke through the parietal pleura with the arrow coming in. But every time the person would inhale and exhale, air would be drawn in and out of the pleural cavity. And when the air was exhaled out, the side where the trauma is, that lung during exhalation might partially inflate. And the reason why it might partially inflate is because of changes in the pressure. So in the pleural cavity, and this picture is shown here on this slide at the top. Let me explain it. So as the air moves out of the pleural cavity, shown here in the top two pictures on the right side where it says expiration for an open pneumothorax, as the air leaves the pleural cavity through that wound, it will create a partially negative pressure and can actually pull the lungs somewhat open. So a person with this type of traumatic pneumothorax might not necessarily have the air dyspnea or air hunger as someone with a tension pneumothorax that I'm going to tell you about in just a little bit. So they wouldn't get an immediate collapse of the lung, or maybe not totally. It's only when the pressure became too great on the outside of the lung that the lung would begin to collapse. Sometimes it would just reduce but not totally collapse. Your trauma pneumothorax is usually in the upwards part of the chest cavity. Again, the higher up it goes, the more likely that air could flow in and out of that damaged region. But now, look at the bottom set of pictures, the tension pneumothorax. The tension one usually occurs towards the bottom of the lung. And the problem with the tension one is it lets air in, but it doesn't come out. Remember, we have higher amounts of pleural fluid in the lower part of the lung because of gravitational pull. And this is going to be part of the answer why we can let air in when we inhale, but when we exhale, that fluid, that pressure is going to occlude the wound, block it, and so the air can't get back out like we saw in the trauma pneumothorax. That's going to be really, really a big problem. So what happens is the pressure keeps building up and building up because every time they inhale, they can't get it out through that wound. And building up, and then boom, not only do you get a collapse, this is the worst kind of pneumothorax. Not only do you get a collapse, but because you're increasing the pressure in the intrapleural cavity, or the intrapleural space, By actually letting atmospheric pressure into the lung, you're literally pushing everything in the opposite direction. Look, in this picture, the damage is on the person's right lung, right? Look carefully on the inspiration. You see the right lung collapsing. That's that little shriveled up mass in that pink space representing the intrapleural cavity. But then notice on expiration that air can't get out. And with time, we're seeing shifting of the heart and collapsing the other lung, the left lung. So you're literally pushing everything towards the left side of the body. You're literally moving the heart, and that, of course, can cause functional problems of the heart, cause arrhythmias of the heart. You can't mess with the heart. You can't just take it out of one place in the mediastinum and move it over into this lung space. So that's the worst kind, the tension pneumothorax. It will cause the whole lung to collapse, but additionally you're pushing the contents of the whole mediastinum over to the opposite side of where the damage happened. So you need to do a thoracentesis. You need to do a needle aspiration. Now, I posted 3 different videos on Blackboard to see how to do a thoracentesis. And basically what you do is, I'll just talk you through it a little bit. You have to make sure you get your midclavicular landmark. The midclavicular landmark is roughly along the nipple line, just roughly. Most people, when they insert their needles in between the intercostal spaces, they go too medially. Now, I purposely picked the video from 3 Kings where Mark Wahlberg, Marky Mark, he gets shot, and he's got trauma pneumothorax, and he's got this air dyspnea, and what's his name? George Clooney comes over and helps him. Now, if you watch that clip, George Clooney inserts the thoracentesis needle way, way, way too close to the sternum, and that's not proper placing, not by a long shot. So I posted another video that shows problems with decompressing traumatic pneumothorax, and it really succinctly shows you, I think it's a military video. If you don't place that thoracentesis needle correctly, then you can pierce the heart and they can bleed out, or if you misdiagnose the fact that they don't have a tension pneumothorax and you insert a needle, you are compromising that pleural cavity now. You're introducing a pneumothorax, and their lungs may still inflate, and every time they inflate, they're piercing the tissue with a needle. So I encourage you to watch all 3 of those videos. It's just kind of fun to go along with this. Okay, so you're out in the field. You're a medic, and you've got a fellow military colleague who's got shrapnel wounds. This is going to create a lot of trauma. Pneumothorax, tension pneumothorax, because you get shrapnel into the rib cage and it starts opening up the air passageways. What you can do is, they have this in the field. They have patches. So they see where the hole is, where the trauma is, and they put a patch over it, literally like a piece of adhesive tape. It's just an adhesive patch. And then they take the needle and they simply insert the needle through the intercostals until they think they're in the space. Now, in one of the videos I show you, if it's loud, you might not hear the air starting to escape through that needle. And again, with a tension pneumothorax, the air can't get out, but with the introduction of the needle in a different place of the wound, you can allow the air to escape. Well, if you are in a loud place and there are bombs going off, you can't hear that coming out. So they recommended one of the videos that I show you having some saline solution in the syringe so that you can see the air bubbles escaping into that solution. So you insert the needle until you're in the pleural cavity, and then you draw the syringe back. They pull the syringe back, the actual plunger, and they're pulling the air out of the intrapleural space. And they keep pulling the plunger back until they see fluid coming into the needle. And then what you can do is you can take the needle out and then patch the area. So you have 2 patches, like you patching your bicycle tire. until you can get them back to the MASH unit or emergency unit to correct it. But you can do that right in the field. It's really neat. I have not seen it personally done, but I have seen a video of one of my fellow previous physiology students. He actually had on a jump drive actual footage of him being in the field talking an Iranian military officer through this actual procedure. There was a soldier, and you could see him. It was amazing. So through the video, I've seen this firsthand, if you will. And the soldier, he had labored breathing. He had dyspnea. He was panicking because he was breathing out of one lung. It was unilateral. And the look on his face, they've got this look like they're grasping for people to hold on to them, as if they're drowning almost, and they're trying to get to the surface of the water. So people with this air hunger, they're grasping, and then this needle's inserted, and they pull the plunger, and they pull the air out, and the fluid starts to get pulled out, and the lung starts to reinflate, and it's just amazing, the transition, because the look on this guy's face, it's like you've just pulled him out of a river from near drowning. I mean, that's one thing, but when you give them breath again, it's just an amazing look on their face. And it looked like Clay, my student, it looked like he had a friend forever, because that injured Iranian soldier just looked at him with such gratitude. And there was a whole bunch of high-fiving. Anyway, one of the videos I show you shows how you can create a temporary plug using literally a latex glove with a finger cut off. But in the video of the Three Kings, and also in the video with the latex glove, they talk about using a one-way valve where it'll let the air out but not go back into the lungs. So you can leave the needle in until you go to transport. But again, if they're breathing now, that means every time the lung inflates, you could have the opportunity, if you've inserted that needle a little too far, of their lungs, the surface of their lung kind of being penetrated by that needle. So anyway, check out those videos, and never attempt to do a thoracentesis without proper training. Okay, so what about hemothorax? Hemothorax can be blood being introduced into the pleural cavity. It could be spontaneous with tissue erosion seen with the diseased lung. It could be a bleeding wound, a gunshot, stabbing, where there's clotting of the blood, and that disrupts the pleural fluid inside the pleural cavity. I've even read a paper where women who have, what do you call it? I just lost. Endometriosis, where the inner lining of the uterus is supposed to be shed every month, of course, during menses, but it grows aberrantly in other places of the body. And in some women, their endometrium grows on the surface of their lungs, literally in the pleural cavity. And so when it's time for them to have their period, not only do they have the shedding from their uterus, but also off the surface of the lung, and then the blood accumulates in the pleural cavity and causes a temporary atelectasis. Could you imagine that? Obviously, that's very rare, but I have read about it. So, again, we're going to have this problem with either pneumothorax or hemothorax. The lung gets to recoil inward, that's atelectasis, and if it's a breach in the actual chest wall, then the chest wall becomes untethered and it will get to recoil outward. So we have the two components, chest wall and lungs, recoiling in opposite directions due to disruption of that suction cup, the pleural cavity. Now let's move on to cystic fibrosis. Just a little thing, I think it's very funny, but back in the times when there was the Black Plague, as you learned about, the midwives, when a child was born, they would say to the mothers, they would tell them to lick the child. And the idea was if the child tasted very salty, then that meant that the child had cystic fibrosis. And of course, back then they didn't know what cystic fibrosis was. But they just said, "Woe to that child which when kissed on the forehead tastes salty. He is bewitched and soon must die." And what they were alluding to was the fact of cystic fibrosis, and within 1 year the child would succumb to secondary lung infections because of the problem with the chloride transporter. So ironically, the original test, this lick test, is still used to some extent. The baby's born, they put a hot pack on the belly of the baby, which causes the sweat glands to open up, and then you lick the baby. Cystic fibrosis babies sweat salt and taste very salty. Now, there's a strip, of course, now that we have that changes color. It's a little more scientific. So if the gene is faulty, you are going to have a problem with chloride secretion. In the patient, the sweat glands, okay, so why do they taste salty? Let me back up. Sweat, the actual fluid that reaches the surface of your body, is derived from plasma. And the sweat glands take the plasma and they put it into the duct that is leading to the surface of the skin. And as this plasma-like secretion, the sweat secretion, passes through all the ducts and is working its way back up to the surface of the body, there are chloride transporters that take the chloride from the sweat in the lumen of the duct and bring it back into the body. And sodium and water should follow. So your sweat should be hypoosmotic compared to blood, meaning your sweat glands, if they are working correctly, can retain the sodium chloride and water. So your sweat should be just a watery secretion, not salty. But in children with the problem with the CFTR, the cystic fibrosis transmembrane conductance regulator, they cannot reclaim the chloride, they do not reclaim the sodium, and therefore their sweat secretions taste very, very salty. Of course, we recognize that internally, in the lungs, this means that the mucin is not going to be well watered down. This is going to clog air passageways. They'll be more prone to infection, opportunistic infections. We also recognize that the pancreas releases bicarbonate buffered mucus. That too will be compromised, not as watered down, and we're going to get a clogged pancreatic duct. One of the interesting websites I put on Blackboard for you talks about pancreatic sufficiency versus insufficiency. And back in the old days with these children, the number one reason they would die within a year was not from necessarily the respiratory infections. Don't get me wrong. Some of them succumb to respiratory infections. But in one of the websites I gave you, they talk about the children eating and eating and eating and eating and eating. And because their pancreatic duct was blocked, they could not digest the food they were eating, the breast milk they were eating, the solid food they might have been eating towards the end of the year. And they died of malnourishment. So, I think that's very, very interesting. Okay. So let me just say again, the normal digestive enzymes could not be released from the pancreatic duct because of that thick mucus, that goo, and it was blocking the enzymes, and they could not be activated. They couldn't get into the lumen of the small intestine. So anyway, it's just like the pancreas, although it was there, wasn't working correctly. Even though it was synthesizing the digestive enzymes, it wasn't able to get to the food itself, and a lot of them died from malnourishment, like I said. Alright, so let's review spirometry. Spirometry is, of course, a breathing test, and you can do static and you can do dynamic spirometry. Static spirometry is simply measuring lung volumes. How much do you breathe out total? How much do you breathe in total? But dynamic spirometry now incorporates the element of time. How much air can you get out in 1 second compared to how much air can you get out total? So Spirometry is going to be concerned with the amount of effort required to move air through the conducting pathways and the ease of lung expansion, that is, compliance. So spirometry, like I said before, can allow us to discern between obstructive versus restrictive disorders. Persons with stiff and non-compliant lungs will tend to breathe at faster rates and keep their tidal volumes low, so they tend to take short, shallow, rapid breaths. Persons with obstructive disorders, problems with resistance, they can usually inflate easily. Like I said, it's a problem with primarily getting air out. They will work harder at getting the air out. They will work harder at trying to overcome the resistance, the natural resistance of your smaller bronchioles collapsing during a normal exhale. And they will tend to take deeper breaths and breathe at a slower rate, especially at exhale. Very long exhales. Think of your pink puffers that I told you about. So I really am hoping that this is somewhat review for you. On this screen, you're seeing pulmonary volumes and capacities. What's the difference between the two? A capacity involves more than one volume added together. So tidal volume. Tidal volume is your normal breath in and out. You breathe 500 milliliters of air in, 500 milliliters of air out. What's inspiratory capacity? Well, if you go from a normal exhale, breathe out for me. Now breathe in to your maximum inhale. Well, you have breathed in your tidal volume. You breathe that initial 500 milliliters in, but then you've inhaled even more, your inspiratory reserve volume. So tidal volume plus inspiratory reserve volume equals inspiratory capacity. Going from a maximum inhale to a maximum exhale is your vital capacity. And if you look at that on the screen towards the right-hand side, that includes your expiratory reserve volume plus your tidal volume plus your inspiratory reserve volume. So inspiratory, expiratory, and tidals added together. Your total lung capacity, of course, is your vital capacity, the amount of air you can move in and out of your lungs, but it also includes the residual volume, the air trapped in your lungs that you cannot physically get out, not until you die, and then some of the air can actually leak out through the bronchioles. But still, some will be trapped in there. I like to think of it like this. If you were to deflate a balloon and let it recoil, do you have all the air out? Can you actually squeeze all of the air out from in between the two latex sides? Impossible. So that's what I mean by residual volume. So what are the types of spirometry that we can do that can actually diagnose a person with obstructive disorders versus restrictive? We can do a dynamic spirometry test. In this test, we are comparing how much air the patient can exhale in 1 second versus how much air they can exhale total if given all the time in the world. So what you do is you take a deep breath in and you blow out into this tube attached to the spirometer, and as the patient exhales, a pen drops along a piece of paper, and the paper's on a rotating drum. So as the person exhales, there's a drum that's inverted in a chamber of water. And when the person breathes out, the air they breathe out displaces the water in the drum, and the drum rises. And when that happens, it causes a pen being dragged along a piece of paper to drop. So if you look on the left-hand picture here, you're seeing this pen drop, and then you're seeing FEV, and that stands for forced expiratory volume. And at the bottom you can read 1 second. So FEV1 means the amount of air exhaled in the first 1 second of exhale. And then you're seeing that the pen continues to drop, and you're seeing another arrow that says FVC, which means for forced vital capacity. So we let them keep breathing out and breathing out and breathing out, really giving it all they've got. And what we do is we take a ratio between the volume of air that they exhaled in the first 1 second versus the total amount of air that they can push out. So we get an FEV1 to FVC ratio. We divide, in the case of the normal person here, 4 liters by 5 liters. And you're noticing that they get an average of 80%. That's normal. A person with healthy lung capacities has an FEV1 over FVC of 80%. Now look what happens with obstructive disorders. I'll remind you, this is a problem with getting air out. And you're seeing that they have a very difficult time getting air out of their lungs, because the more they exert, the more they're causing the collapse of those bronchioles. So they get very little air out in that first second. Remember, our pink puffers, they're going to take long outward breaths. They're really going to work hard at it. So they're going to breathe out longer than a normal person. But still, look what happens. The amount of air they breathe out in the first second is certainly compromised, and they still can't get out as much air total as the normal individual. So their FEV1 over FVC, notice in this example, has dropped down to 42%. Below 80%, that's a classic sign of an obstructive disorder. Now, if you come to my class and you do this spirometry and we get something less than 80%, I'm not going to accuse you of having emphysema. We might wonder, do you have a chest cold? Are you having any mucus production, and that's creating obstruction? Of course, there are other reasons why we can have moment or daily to daily changes in our FEV1 to FVC. But in this case, it's chronic, it's obstructive, it's less than 80%. That's the diagnostic tool. Restrictive disorders. Look at this picture and compare it to normal. You're seeing that FEV1 and FVC are both reduced. The person cannot get air in. They have no problem with getting air out, but they just can't get it in. So what little air they do get in, they can get that out, like I said, with no problem. So what we're seeing is that they have reduced forced vital capacity. Less air they can push out. Why? Because they got less in to begin with. But notice that the air they get out in the first second compared to the total air they can move out, the ratio of those two is still 80%. So a restrictive person will have reduced pulmonary values, reduced spirometry values, I should say, but the ratio of FEV1 to FVC will still be a normal ratio. So again, that's how we can use dynamic spirometry as a tool to diagnose obstructive versus restrictive disorders. Now I'd like to finish up the last two slides with first of all, this slide, a discussion on disorders of the pulmonary circulation. So, deep vein thrombosis. When you have a thrombus, or which is a trapped blood clot in a vein, where does it tend to go? To the right side of the heart. Anytime you have a thrombus in the systemic circulation and it becomes an embolus, it detaches and starts moving, it's going to go to the right side of the heart. And that means it's going to move to the pulmonary circuit and become a pulmonary thrombus all over again. If, however, you start with a pulmonary thrombus, where is it going to go? It's going to go to the left side of the heart and then go and lodge again in a systemic capillary bed. So you have to stop and think of your blood flow. So let's focus on a thrombus in the systemic circulatory system. So your vena cava is going to bring the thrombus, now an embolus, of course, up to the right atria, down to the right ventricle, and out the pulmonary artery. Then it's going to progressively get smaller and smaller and smaller in radius, this blood vessel. And then it's the thrombus is going to be too large for that blood vessel. And this can cause instant death. Where do you see this? How can this happen? Airplane travel. And that is why they want you to get up and walk around. because people who are predisposed to forming a blood clot, say they have too much clotting factors or a tendency to clot, activated platelets, they're on a plane sitting from India to Chicago, they can actually develop a thrombus in the lower leg. Anytime you are non-ambulatory, you risk deep vein thrombosis. Years ago, when patients were bedridden, about every 3 days, they knew the patient could develop thrombus in the legs, and the idea was they would have volunteers come in and massage the legs. What they found out was, after keeping records, they found that right after the massage, they were losing patients, because what they were doing was breaking the thrombus loose, and now it's an embolus, and then it would become lodged in the pulmonary capillary beds, and this would cause instant death, of course, from ventilation-perfusion mismatching. So now they use stockings for compression to keep them from forming in the first place. So these sequential compression devices, they're like little air socks that you put on, and there's a machine that will randomly inflate them and then deflate them. And they put this especially on pregnant women who've had a C-section or an epidural and they can't walk yet. So until that anesthesia wears off, they put these sequential compression devices on them, and I find them highly annoying, just so you know, because you've just given birth to this parasite, your hormones are raging, you're hot as heck, and they put these big leg warmers on you, and they inflate and they deflate, and you're trying to sleep at night. I just find them hugely annoying, but I guess they're less annoying than having a deep vein thrombosis becoming dislodged and becoming an embolus, and then getting lodged in my bronchial capillary beds. So again, that can cause instant death because of changes in ventilation and perfusion exchange. This can lead to pulmonary hypertension, and the reason why it can lead to pulmonary hypertension is because when there is a block in the arterial because of this thrombus, that means there's going to be a buildup of CO2. Remember, that's oxygen-poor blood. And CO2 in normal systemic capillaries, of course, is a local chemical to cause vasodilation. But in the lungs, it works reverse. Everything's reverse in the lungs. High oxygen content leads to dilation, vasodilation. Low oxygen content or high CO2 leads to vasoconstriction. And then the gases also have an effect on the bronchioles too, and I'm going to show you this on the next slide. So anyway, there's a reflexive vasoconstriction because the high CO2 content in the blood, and it's not flowing well because of the thrombus. So this means you now have higher blood pressure because of blood damming up, pulmonary hypertension, and this can lead to cor pulmonale, which means that now the right side of the heart is going to have to work harder to overcome that pulmonary hypertension. So we'll start to see the right ventricular hypertrophy occur, and of course the right axial deviation when we calculate their mean electrical axis. So I thought you would find this useful if you've not had me for physiology, and now you're starting to hear me say how the lungs behave differently to our blood gases. I thought maybe this might be helpful for some of you when you go to nursing school to have it as a reference check. Again, pulmonary capillary beds, and also you should hear me, renal capillary beds, the glomeruli, they just respond to these blood gases differently than systemic capillary beds. And you can work yourself through this chart real easy. Here's what you do. Step 1. Remind yourself what the blood gases do in a traditional capillary bed. How do they normally regulate blood flow? Of course, if a tissue bed is metabolically active, we recognize that there is more CO2 and less O2. We recognize that that tissue bed would like more blood flow. So the CO2 in excess and lack of O2 both will cause the precapillary sphincters to relax and restore blood flow. Now, once you remind yourself what happens in a traditional capillary bed, Reverse it for the pulmonary capillary bed. High CO2 leads to vasoconstriction. Low O2 leads to vasoconstriction. So you can see that over here in the black column all the way to the right. Increased CO2, you're seeing constriction. Decreased O2, same kind of thing, constriction. When there's a lot of oxygen in the blood and decreased CO2, that's when we get the dilation. The idea is to move the blood through the pulmonary circuit and get it back to the left side of the heart to get it to the tissues. If it's well oxygenated, let's move it along, little doggy. But then look at the response of the bronchioles. It's the opposite of what you would see in the pulmonary capillary beds. So let's focus, let's say, on the increased CO2 and decreased O2, because that goes together. If you have increased CO2, more waste product, well then you have less oxygen. So look at the top row and the bottom row. Look all the way to the right. We see that increased CO2, decreased O2 leads to constriction of the blood vessels in the pulmonary circuit. But it has the opposite effect for the radius of the air passageways. It causes dilation. Now, if the system could talk to you, it would say the following. You know what? We have a capillary bed surrounding an alveolus where we don't have proper perfusion, ventilation, exchange. Don't bring the blood here. Let us open the air passageway for this alveolus. Let's ventilate out the CO2. Let it get out. Let it get out. Bronchial dilation. Let's move that bad gas out of here. And let's not bring blood in the capillary bed because we've got dirty air here. There's no reason for gas exchange. We don't have good quantity of oxygen. So that's the purpose of this opposite effect. Shunt the blood away, but open the air passageways. If you look at the two middle rows, decreased CO2 and increased O2, well, now you want to bring the blood to that pulmonary capillary bed. Let's get the oxygen loaded on. And you want constriction of the air passageway. Don't waste more time ventilating to that alveolus. It already has good quantity of oxygen. Let's bring the blood to it, allow the gas exchange, and then move it on, little doggy. Alright, that concludes our discussion on disorders of ventilation and gas exchange. I hope you enjoyed it, except for the part of me having a mild asthma attack last night. Okay, next, onward to disorders of fluid and electrolyte balance. Super fun.